Alright, colon and rectum. Let's get started. So we'll start with some embryology. Begin at the 4th week of gestation, the primitive gut, which turns into the foregut, the midgut, and the hindgut. Primitive gut is derived from the endoderm. Your midgut goes into small intestine, that ascending colon, proximal 2/3 of the transverse colon. It makes that 270-degree rotation around the SMA. It happens around week 6. Its blood supply is from the SMA. Your hindgut is the distal 1/3 of the transverse, descending colon, rectum, proximal anus. Its blood supply is from your IMA. Colon anatomy begins at the junction of the terminal ileum and the cecum and extends 3 to 5 feet until it reaches the rectum. It's comprised of 5 wall layers. From inside to out, every mucosa, submucosa, inner circular muscle, outer longitudinal muscle, and your serosa. The outer longitudinal muscle separate to form your tinea coli. These tinea converge at both the appendix and at the rectum. So they can be useful during an appendectomy to identify the appendix. You can follow the tinea down until they converge. The cecum is the widest diameter of the colon, and it has the thinnest walls. So due to having the thinnest walls, it has the increased risk of perforation, but since it's the widest diameter, it has the lowest risk of obstruction. The ascending and descending colon relatively attached to the retroperitoneum, and that's via the white line of Tolt. Sigmoid is the narrowest in diameter. It's extremely mobile since it does not have retroperitoneal attachments. So since it's mobile, its risk of volvulus is the highest, and its risk of obstruction is also the highest since it's the narrowest region. And then your haustra are formed by the plica semilunaris. So colon vascular supply. You have your SMA, your IMA. Your SMA branches out to your little colic, your right colic, your middle colic. And the IMA goes to your left colic, sigmoid branches, and it also supplies the superior rectal. So your iliac colic goes and supplies your proximal ascending colon, your right colic is your ascending colon, middle colic is your transverse colon. And then your left colic, you have your descending colon, sigmoid branches supply the sigmoid, and the superior rectal artery goes to the proximal rectum. Then you have your marginal artery, which runs along the colon margin, and that connects your SMA to IMA, providing collateral flow. It's not a direct connection, though. It runs along the colon margin, also known as the artery of Drummond. There's another artery called the arc of Rheolon, which actually is more central, and that basically attaches the IMA and the SMA pedicles, also supplying collateral flow. Your venous drainage follows arterial, except the IMV, which goes to the splenic vein. The splenic vein then joins the SMV to form the portal vein behind the pancreas. Here's your blood supplies. So your artery of Drummond follows the colon margin. Arc of Rheolon, kind of hard to see here, but it's just a short segment between the IMA and the SMA. Don't actually think it's depicted here. That's your arc of Rheolon. anal rectal landmarks. So your rectum is approximately 12 to 15 centimeters in length. Has 3 valves, known as the valves of Houston. These are submucosal folds, and they're situated same picture. Talk about some of the sphincters here. So your external sphincter, which is a continuation of the puborectalis muscle. It's under CNS voluntary control. It's the external. It's what allows you to defecate. It's what allows you to hold in going to the bathroom. It's supplied by the inferior rectal branch of the internal pudendal nerve. And it's also a continuation of the levator ani muscle, so it's a striated voluntary muscle. The internal sphincter is under involuntary control. It's a continuation of the muscularis propria, so it's a smooth muscle, involuntary. It's normally contracted. Vascular supply of the anus and rectum. So you have your superior rectal artery, which is a branch of the IMA, which comes from the hindgut. It supplies the upper 1/3 of the rectum. Then your middle rectal artery, which is a branch of the internal iliac, which supplies the middle 1/3 of the rectum. Then your inferior rectal artery, which is a branch of the internal pudendal. Apparently I cannot spell branch on this slide. Supplies the lower 1/3 of the rectum. Superior and middle rectal veins drain into the IMV, which go to the portal system. The inferior rectal vein goes to your internal iliacs, which vein goes into your caval system. This is one of the portal caval areas of shunting you see throughout the body. So here's a graphic of your blood supply. Innervation. So your internal anal sphincter, as we said, is sympathetic and parasympathetic, which both inhibit contraction. External anal sphincter is inferior rectal branch of the internal pudendal nerve. Levator ani is the internal pudendal nerve, and direct branches from S3, S4, and S5. And then sensory to your anal canal is the inferior branch of the pudendal nerve. Some physiology. So the colon secretes potassium and reabsorbs sodium and water, mostly in the right colon and cecum. Colonocytes are going to be dependent on short-chain fatty acids as their main nutrient. Some motility. So you have intermittent contractions of either low or high amplitude. The high amplitude occur in coordinated fashion, creating mass movements. And then your low amplitude, these occur in bursts, which is thought to delay transit, which leads to an increased time for reabsorption and electrolyte. Absorption of water and electrolytes. And defecation. So, into some clinical things now. This is a little more interesting. So, these are some of the topics we're going to be covering here. IBS, IBD, diverticular disease, some cancer, some syndromes, and some other kind of random ones. So IBS, this is a pain syndrome associated with diarrhea, constipation, or both. They can have one or the other. 1 week have diarrhea, the next week have constipation. It varies. There's no actual diagnostic test. It's more of a diagnosis of exclusion. It's not associated with any weight loss like other how some valve problems are. So pain will be relieved with bowel movements, and it's usually less at night. To treat IBS, usually conservative management, lifestyle changes, on a high fiber diet, try to bulk up that stool. And then you can try some antispasmodics, such as dicyclamine or hyoscyamine. Your TCAs, loperamide can be used for diarrhea predominant. And then there's the chloride channel activator, lubiprostone, which is for your constipation dominant. And then there's other ones such as Xifaxan or rifaximin, which is actually an antibiotic. That is a newer treatment for IBS as well. I believe it's for diarrhea dominant IBS. So IBD, Crohn's, and ulcerative colitis. Start with Crohn's, intermittent abdominal pain, diarrhea, and weight loss. Weight loss now we're talking about, IBS was not associated with weight loss. You can also have other things such as obstructions or fistulas. So it's usually first presents between the ages of 15 and 35, but it is a bimodal distribution. So the first presentation is 15 to 35, and then the other time it presents would be in the later 40s, 50s. Some of the extraintestinal manifestations here are arthritis, arthralgias, pyoderma gangrenosum, erythema nodosum, and then some vitamin deficiencies. This can occur anywhere in the mouth, anywhere from mouth to anus. It usually spares the rectum. So it's not only to the colon, which comes into play later. Your terminal ileum is the most common site to be involved, and then your distal ileum is the most common site that becomes perforated, if it were to perforate. Some more on Crohn's. So it's diagnosed with colonoscopy and biopsy. Some trigger words is transmural involvement, skip lesions, so it's not continuous. It can occur in different areas. Cobblestoning, you can see ulcers. Fistulas. Creeping fat is actually something you'd see more intra-abdominally, not on a colonoscopy. So you would see that during a diagnostic lab or an X lab of some sort. So your treatments, so maintenance, you can use the 5-ASA analogs, such as salamine is a common one, and then loperamide to control the diarrhea. For a few acute flares, usually use steroids such as like prednisone. And then for people who have developed fistulas, you can try infliximab, the TNF inhibitors. So for Crohn's disease, you don't want to take these patients to the OR unless you have to. They don't heal well. So some of the indications would be some kind of obstruction. If it's an abscess that's not drainable, to an IR drain or some kind of pigtail intervention. If they develop a megacolon, if they're hemorrhaging, and then if they've developed fistulas that are not amenable to medical treatment. So Crohn's is anti-Saccharomyces cerevisiae antibody positive, ASCA positive. So ulcerative colitis, you have bloody diarrhea, abdominal pain, fever, weight loss. Weight loss is different from your IBS. It involves only the mucosa and submucosa. It is not transmural, like Crohn's. It spares the anus. It does not have skip lesions. It's more contiguous. You need to rule out an infectious etiology such as celiac sprue. Also diagnosed with colonoscopy and biopsy. Your medical treatments are similar with 5-ASA, loperamide for the diarrhea for maintenance. Use steroids for acute flares. And then your infliximab or cyclosporin for steroid resistance. Some complications of ulcerative colitis. Toxic megacolon, which is defined as 6 or more bloody bowel movements per day with fever, tachycardia, and leukocytosis. Then if you take that and add distension, abdominal pain, and tenderness, it becomes your toxic megacolon. Treatment is going to be decompression with G-tube, IV fluids, steroids, antibiotics. In ulcerative colitis, your transverse colon is more likely to perforate. It's the most common site versus Crohn's, or is it distal ileum? So cancer risk increases 1% per year starting 10 years after initial diagnosis. And these patients need yearly colonoscopy starting 8 to 10 years after their initial diagnosis. So UC patients are ANCA positive as opposed to the Crohn's patients, which were ASCA positive. So UC ANCA positive, ASCA negative, Crohn's ASCA positive, ANCA negative. And then you can use erythema nodosum as an indicator for your disease activity. Here's a basic chart, which I'm sure you all have seen before, comparing the two. We pretty much covered everything up here. The last additional fact would be that tobacco use is said to be protective in ulcerative colitis patients. So here's your first question. Go ahead and read it, pause it. So C, talking acute diverticulitis. Try to trip you up, talking about IBD, but I'm doing a question about diverticulitis. The left lower quadrant pain, CT scan is going to be your best test. Diverticular disease, so you have diverticula, which is herniation of the mucosa at sites where arteries enter the mucosal wall. You can have bleeding, which is most common on the right side. You can have diverticulitis, which is most common on the left side. Diverticulosis is usually asymptomatic, but it can have some left lower quadrant pain, constipation, and bleeding. Diagnosis is with colonoscopy. It can also be seen on CT scan. You see, you can prevent with increased dietary fiber. And bleeding is caused by disrupted disease of recta, and it's arterial in nature, so these patients can bleed quickly and decompensate quickly, as they can lose large amounts of blood in a short period of time. Diverticulitis, this is a result of mucosal perforation in the diverticulum, adjacent fecal contamination. So these is, by definition, microperforations, not necessarily a large gross perforation. So they're going to have left lower quadrant pain and tenderness, as opposed to just pain. They'll be tender. Could have fever or an elevated white count. Best initial test is your CT scan. You do not want to do a colonoscopy or a barium enema in acute flare, acute phase. Increase the risk of perforation. But these patients will need a colonoscopy usually 6 to 8 weeks after resolution of their symptoms. Medical treatment, if it's uncomplicated, just bowel rest and antibiotics, IV fluids. If it's complicated, then they'll need to be taken to the OR. Some examples of complicated is a obstruction, a gross perforation, abscess, not drainable, fistula, frequent recurrences. So abscesses and diverticulitis are broken into the Hinchey classifications. So you have Hinchey 1, which is a simple abscess, pericolonic. Hinchey 2 is pelvic abscess. Hinchey 3 is purulent peritonitis. And Hinchey 4 is fecal peritonitis. So it's stool in the abdomen. Colorectal cancer, second leading cause of cancer death, third most common cancer. Can present with anemia, constipation, and bleeding. These are 4 genes of progression: APC, KRAS, DCC, P53. That's the order. APC, KRAS, DCC, P53. And these are the chromosomes are on could be important. So APC is going to be on chromosome 5, DCC is on chromosome 18, P53 is on 17, and KRAS is on 12. Testable. Sigmoid colon is the most common site of a primary tumor. Colon cancer usually spreads to the nodes first. It mets to the liver via the portal system. It mets to the lung via your iliac vein. Rectal cancer can metastasize directly to the spine via Batson's plexus, which are valveless, which is what makes them unique. Polyps, hyperplastic, is the most common polyp. Doesn't carry any significant cancer risk. Tubular adenomas have about an 11% risk. It's the most common neoplastic polyp. Then you have your tubular villus. Villus adenomas are the most likely to progress to carcinoma. They're generally sessile. In general, anything greater than 2 centimeters, sessile or villus, is going to be worrisome for cancer. So screening, yes, probably all already know this, hopefully. Start at 50 for normal risk patients. Start at 40 in anyone who has a family history of colon cancer or 10 years prior to the youngest case in the family. So for normal risk patients, you can do colonoscopy every 10 years, or you can do hemocult every 3 years and a flex sig every 5 years, or hemocult annually. You can get some false positives with your hemocult test. People that eat large quantities of beef, vitamin C, iron, cimetidine, Pepto-Bismol, things like that. Patients with a previous polyp, they're going to get scoped every 3 to 5 years, depending on how many polyps there are, location, and history. And then patients with previous colon cancer who've had a resection, they're going to get a colonoscopy 1 year after resection, then 3 years, then every 5 years. 5 years after that, assuming there's no further polyps or lesions found. So some other syndromes. FAP, thousands of polyps, autosomal dominant, it's found on the APC gene, which is again chromosome 5. Screening starts at age 12. Every year with a sigmoidoscope. You don't need to do a full colonoscopy, because once you put the scope in, get to the sigmoid and you'll see thousands of polyps. You don't need to see any more. These patients are going to need colectomy by age 20. Some associated syndromes. You have Gardner's, which is your desmoid and osteomas. Your Turcotte's, which is related with brain tumors. And these are both also APC related. Then you have your Peutz-Jeghers syndrome, which is hamartomas, the melanoma spots on the lips and skin. And then these patients also have increased frequency of breast, gonadal, and pancreatic cancer. And Peutz-Jeghers is associated with the STK11 gene. It's a photo of your FAP, just studded with polyps. Blood syndrome. Rectum, DNA mismatch repair gene. There's Lynch 1 and Lynch 2. One is colon cancer only. Lynch 2 brings in ovarian, endometrial, bladder, stomach. Follows the Amsterdam criteria, 321. 3 first-degree relatives. So that's parents, siblings, children. Doesn't take into effect grandparents or aunts or uncles, things like that. Has to span over 2 generations, and there has to be one cancer prior to age 50. Surveillance for these patients, you start with colonoscopy at age 25, or 10 years prior to the youngest, and that's every 1 to 2 years. Volvulus, so you have sigmoid and cecal. Sigmoid is more common, because the sigmoid does not have the retroperitoneal attachments like we talked about earlier. Present with pain, distension, obstipation. It's a closed lip obstruction. On X-ray, you can have that bent inner tube sign. You can describe it as ace of spades or a coffee bean. Treatment, you can attempt to do a decompressive colonoscopy. Unless you have gangrenous bowel or peritoneal signs, then you would want to go to the OR for an X lab. If you are able to do a decompressive colonoscopy, then you can optimize the patient, do some cardiac risk stratification, and do a semi-elective sigmoid colectomy during the same admission. So your cecal volvulus is less common than the sigmoid. Decompression isn't really as used for this. It's not successful, only 15 to 20% success rate. So these patients, more than likely, are going to need a trip to the OR. Right hemicolectomy is the procedure of choice. But also, if patients won't be able to tolerate a big procedure like hemicolectomy, and the bowel's viable, you may be able to just pexy the cecum. Here's a X-ray of sigmoid volvulus. As you can see, it points up to the right upper quadrant, so they point to the opposite direction. So a cecal would point to your left upper quadrant. Intussusception, this is in adults, usually from small bowel tumors or cecal tumors. They're most commonly kind of present as an obstruction. They often have a malignant lead point. So these patients, if an adult comes in with an intussusception, it's cancer until proven otherwise. And you need to resect these. You don't typically reduce these like you do in children. Appendicitis, so your standard presentation is going to be anorexia. Periumbilical pain, which becomes more focal and migrates to the right lower quadrant. Vomiting. You have your clinical diagnosis. CT is helpful, but not necessary. You can use your test as SOAS, obturator, and Rovsing's. If you do get a CT scan, which most of the time the ED gets these, hyperplasia is the most common cause in children, and fecal is the most common cause in adults. Treatment is appendectomy. Prefer laparoscopic if you're able to. And then Yersinia can present as a pseudoappendicitis. I've never actually seen a question on this, but I always mention it. Ogilvy's is a pseudo-obstruction of the colon. It's associated with opioid use, bedridden or older patients, recent surgery, infection, or trauma. You want to rule out mechanical obstruction. CT can be helpful for that. Make sure there's no adhesion or volvulus. So then you want to check and replace electrolytes, especially potassium. Decompression with an NG tube. You can try neostigmine. If you're going to try neostigmine, you want the patient to be on a monitor or an ICU, and have atropine at bedside in case they become bradycardic. Angiodysplasias, These are venous bleeds, so they're not as severe as diverticular bleeds. They have an association with aortic stenosis. If you repair the aortic stenosis, your angiodysplasas will likely resolve. C. diff colitis, you're going to see pseudomembranes, watery green, mucoid diarrhea, pain. Occurs up to 3 weeks after antibiotics. Neutrophil inflammation or mucosa, submucosa. Diagnosis with C. diff toxin. Treatment is oral flagyl, times 2 rounds. So if it fails the first round, they come back, try oral flagyl again. If that fails, then you move on to oral vanco. Oftentimes, if their white count's above 15,000, we go straight to oral vanco. Hemorrhoids, you have your major columns, your left lateral, right anterior, right posterior. The minor columns are just the opposites of that. Your external hemorrhoids are going to be painful. They're distal to the dentate line, squamous epithelium. Internal, they often present with blood on the toilet paper, just streaks of blood. They could have some pruritus. The 4 grades of internal hemorrhoids. The primary, these will slide below the dentate line with straining. They don't ever come out externally. Secondary are going to come out externally, but they'll spontaneously reduce. Tertiary, these need to be manually pushed back. And then quaternary, these are non-reducible. So usually 3 and 4 are the ones that people seek treatment for. Initial treatments, fiber and stool softeners, just try to decrease the pressure required to defecate. Surgical indications for recurrence, thrombosis, large external components. You can ban primary and secondary internal hemorrhoids, but you don't want to ban any external because it can be excruciatingly painful. So here's your internal hemorrhoids here. External, this is probably was 3 or 4 that made its way out there. Fissures, so fissures is split in the anal derm. Most common posterior midline. You're going to present with bleeding and pain associated with defecation. Be afraid to poop. Treatment: sitz bath, lidocaine jelly, stool softeners. Your surgical treatment is lateral internal sphincterotomy. So if a patient comes in and has a lateral fissure, or really anything besides posterior midline, these patients, you want to have a high suspicion for Crohn's, especially if they fit the age group. So you want to do a colonoscopy or some kind of further workup for Crohn's. So here's some more questions. Go ahead and read them. Alright, so the rest of this is going to be questions. So you can either pause it or I'll give about 20 seconds per question. So if you need more time, just pause the videos. So sigmoid is a quick, easy one. Anal fissures. You're going to start with medical treatment, sitz baths, lidocaine jelly, stool softeners, nitrate pastes, things like that. Then you would do the lateral internal sphincterotomy if these failed. Adhesions are most common in patients that have prior surgery. This patient had some scars on her belly, so you know she had some kind of surgery in the past. So the air's not reaching the stomach, so obviously some kind of disconnect at the proximal of the stomach, so that's the most viable answer. Richter's hernia, part of the colon wall is involved, so it's kind of a partial obstruction. It can kind of come and go. So you're still going to have regular bowel movements. So Meckel's in an adult is most likely going to present as an obstruction, versus in kids, they have the bleeding. So small bowel comes from the midgut. Talked about it in the beginning of the lecture. So this is your sigmoid volvulus. The key was the massive distended loop in the right upper quadrant. Talked about that the right upper quadrant is sigmoid, left upper quadrant is cecal. Your MMCs. The inhibition of these can lead to your nausea and vomiting because you're not able to move things along, so you kind of get backed up. Crohn's. Got your segmental fecal stream. So this is your tagged red cell scan, which is the most sensitive test for to find overt bleeding. It's the least specific, though, of the three. It's just kind of a blur on the image. Tells you the area that something's bleeding, but doesn't tell you what or really specifically where. angio is going to be most specific. And CT is kind of in between. Angio, you're able to also, it's not only diagnostic, but it could be therapeutic. Able to put coils or a covered stent in. This is just asking how you can assess the viability of the bowel. Just check it. You can use it. Look for pulses. You can bring in a Doppler in. You can look for peristalsis. Just look for the color of the bowel, if it's changed, if it's pink or dusky, things like that. So the cirrhosis appeared more normal on inspection. So in Crohn's, you'd expect the cirrhosis to be involved since it's a transmural involvement. With the cirrhosis appearing normal, you would think more ulcerative colitis, since that only affects the submucosa and the mucosa. And the last question. Alright, so hope you enjoyed your lecture. Good luck.